Hey everybody, today we're going to talk about metabolism and we're going to focus on diabetes type 1 and insulin. Objectives for this session, we're going to talk about blood glucose levels, how they are maintained within the body, talk about the etiology, compare and contrast insulin types, definitely talk about signs and symptoms related to insulin. We're going to do our farm focus on regular insulin, the prototype drug, and we are going to dive very heavily into the nursing process for clients that have diabetes type 1. It'll span into type 2 a little bit, and always patient education and the things that you need to do as the nurse. All right, so in the pancreas, you have these isolates of Langerhans cells, and those secrete insulin and glucagon. Glucose is essential for the body and it's its primary energy source, especially for the brain. When we're talking about insulin and glucagon, you know that insulin comes from the pancreas and it's going to decrease blood glucose levels. Glucagon, also from the pancreas, is going to increase blood glucose levels. So this delicate balance, this dance that's happening, is going to try to, within the body, maintain a constant level of glucose throughout the day. But throughout the day, things go up, things go down, but ultimately the goal is to have some balance. But what if? So if there's no insulin, the glucose is going to stay in the bloodstream. It's not going to be able to enter the cells. So when we think about insulin and we think about glucose, they are a team. And on that team, the insulin is the gatekeeper. The insulin is the one that says, hey, I showed up with the key now. I'm going to open the door for the cells so that we can go ahead and get that balance. What you need to be mindful with when it comes to blood glucose and particularly insulin, and even with oral anti-diabetic agents, is hypoglycemia and hyperglycemia. So hypo is low blood glucose, and this is due to the insulin. You need to know some common medications that can affect this so that you can educate your patients. Alcohol can cause hypoglycemia. Lithium, ACE inhibitors, and beta-adrenergic blockers. So I'm just kind of bringing those in because we're going to talk about the ACEs and BABs a little bit later in perfusion. Hyperglycemia, things that can kind of increase that is going to be steroids, corticosteroids. I hope you're familiar with that. NSAIDs and diuretics. All right, so just a little overview with type 1. It was formerly called juvenile onset diabetes. You may still hear that term, and that's because it gets recognized and diagnosed typically in a younger age population. It's also called insulin-dependent diabetes. What happens is the pancreatic beta cells, there's destruction of those, and now the pancreas doesn't have the ability to secrete insulin. So it can't even do its job. There is no insulin. So what we need to do and assist with our clients is to provide them with education so that they know how to take their insulin. Common signs and symptoms you're going to see are hyperglycemia, typically greater than 126 milligrams per deciliter. They're going to have the 3 P's. I call those the polys: polyuria, polyphagia, and polydipsia. So those are our nurse words. So I want you to go back and look at those and what is that, and put it in a way that you could eventually educate your patient. You may see glucose in the urine. So glucose is like a really big molecule, and it's in the bloodstream, and it should stay there, and it should be processed in the body. What you need to know is you should not see glucose in urine. If you do, that's a problem. We call that kind of like spilling into the urine. They may have weight loss and fatigue, and not to make it a gray area, they may even be asymptomatic. Some common diagnostics that you're going to see with care to clients with type 1 is a hemoglobin A1C. So I want you to go ahead and look up that diagnostic. And typically, we want clients to be less than 6.5%. That's kind of like the number you want to keep in your head. If it's greater than that, that A1C is not, or their diabetes and insulin or whatever therapy is not being managed. It's actually a test that kind of looks at the last 3 months of a client, and we'll probably talk about it a little bit more later. You might see fasting plasma glucose. This is where a client's going to fast at least 8 hours, and then a blood glucose greater than 126 milligrams per deciliter would be indicative of diabetes. Oral glucose tolerance tests, you see a lot of these with our pregnant women. They'll go in and ingest 75 grams of glucose, which does not taste good. I did have this test done. And then they're going to check the glucose. They call it a 2-hour glucose. And if the blood sugar is greater than 200 milligrams per deciliter, that could be positive for diabetes. Taking it a step further, from my experience as a patient, when that happened to me, they did a subsequent test for a longer duration of time and kind of put those two tests together. Same thing, it was still with the glucose, but we had to do another test with it. Untreated diabetes can cause a whole host of problems, so I hope you bring this forward when you learned about this, but let's just go over it a little bit. Remember I said those glucose molecules are large. What's going to happen is they're going to occlude and damage arteries and capillaries, especially at the most distal ends of our extremities. So first, we got to go back to perfusion, because all roads lead to perfusion. If I don't say this enough, when you think about concepts, you think about anything you're learning, all roads lead back to perfusion and oxygenation. Diabetes tends to create or comorbid with cardiac disease. So if you ever watch those farm commercials, not only do those medications help with managing blood glucose, however, they also help with preventing cardiac disease or complications that kind of tie into that. Heart attacks, MIs, stroke, and death, just to name a few. Damage to the kidneys. High blood glucose levels have a significant effect on those kidneys. Over time, kidneys will continue to get damaged. Moving fast forward just a little bit, later in your program, we're going to talk a lot about chronic kidney disease, and I will tell you it's not uncommon if you have a chronic kidney patient. They also have diabetes. They also have hypertension, high lipidemia, and most importantly, the diabetes and the kidney disease play into effect. They can get retinopathy, again, damage to those small little areas, and eventually have blindness. The poor circulation to the feet and the toes, this is going to cause decreased sensation. That puts them at 2 risk 4 items that are very important. 1, risk for injury. If I have decreased sensation, I can't feel my feet. I'm trying to walk down the steps. You know, you need all that to kind of feel where you are. They could fall down the steps. Another very important, risk for infection. That's why I had a very good friend, and I would yell at her all the time. I said, do not walk around in your bare feet. You put some flip-flops on. And that's because if I walk around and I step on something, I'm going to feel it. And I'm going to look at my foot and be like, oh, and I'm going to take care of it. When you're diabetic, you don't feel that. So you could go days and then ultimately develop an infection. And then you could go days more, and that infection turns into a severe infection, and then we're dealing with life-threatening sepsis. It could happen. For sensory perception, too, they can develop neuropathies. They also, on other things, can develop ketoacidosis. And this can be manifested with a fruity breath odor, and there will be ketones in the blood. May also see ketones in the urine. You don't want ketones in the urine. This could ultimately lead to what's called diabetic ketoacidosis, and you're going to see signs and symptoms of hyperglycemia, and it's going to be high, nausea, vomiting, severe fatigue, level of consciousness changes, and it could lead to coma and death. All right, so insulin. Insulin is the mainstay for type 1 diabetics to kind of help regulate everything. It can also be used in type 2. So let's just go ahead and discuss insulin now. And then when we get to type 2, we're going to focus on the oral anti-diabetic agents. First thing, you've always got to know insulin administration. This really needs careful planning because the meals, the timing, activity, they all play together in how the body is going to respond. And you also need to consider the client's lifestyle choices and habits. So we're going to have a lot of conversation to find out what clients are doing. For outcomes overarching, we want to help the client maintain blood glucose levels within normal limits, so you should know normal. And then remember, again, insulin is a gatekeeper and it is needed in the body. If they don't have the insulin, it's not compatible with life. For your considerations as a nurse, again, remember the body needs glucose with the insulin because they're a team. You need to consider administration of timing in conjunction with the meals. It is an absolute must, and we're going to talk about that a little bit later. Account for exercise. Again, exercise plays in and can fluctuate glucose levels. When it comes to insulins, you have got to know the onset, peak, and duration of the types of insulin that we're going to go over just briefly. And always, 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 nurses, we need to think 10 steps ahead of ourselves. We need to prepare for any potential outcome with our client. So be prepared when we're administering insulin that we have a plan in place if the client becomes hypoglycemic. You need to know how to treat hypoglycemia. So for example, maybe we need to give them a snack, food, drink, something, a little bit of carbs, maybe something with sugar. Maybe then I have to have IV or IM glucagon, which could be delivered as well. And as a last resort, IV dextrose. This is a very common thing called a hypoglycemic protocol in the agency. So next time you go to clinic, when you get some time, find their hypoglycemic protocol and help reinforce that. Also, be aware of hyperglycemia, because if I give insulin, the expectation is the insulin is going to work and it's going to decrease the blood sugar level. If it doesn't, then there's probably some problems there that we need to think about. Is the insulin not working? Is there some other problem? Was it the wrong dose? Do I need more? Do I need a different type, a rapid versus an intermediate? Those are some things that you want to consider. For insulin types, I've already went there. There's 4 common ones, and those are rapid, short, intermediate, and long. There is a table in your book. You do want to look at it. Every good nursing book and drug guide has this table. We're going to talk about that a little bit later. Again, you have to know the onset, peak, and duration. You have to do it with the meals. You have to take that in consideration. You have to look at the method of administration and know how do we administer insulin. Very common, sub-Q. One of them can be given IV, and that's when we would do an IV titration, insulin drip. And then compatibility. You are going to be giving your clients multiple types of insulin, and they are different. And they don't all play in the sandbox together. Some you can mix and some you cannot. So my general stance is this: if you don't know, if you're giving 2 insulins at one point of care administration, you need to do your research first to say, is this compatible with this type of insulin? Final thought, again, those textbooks have a chart, but you cannot sit there and memorize that chart because that does not give you any meaning or why to it. So at some point we're going to do a quick activity because I want you to deconstruct all of that information so that you can truly understand why those meals, those AccuChecks, that insulin administration, and how all that plays together so you can understand and teach your patients. So let's do a little application to your future practice. I want you, after I finish with this slide, I want you to pause the video. I want you to go out and get a piece of paper. And I want you on the top of the paper to put time in a column, or I'm sorry, in a row running across the sheet. And let's start with 6 a.m. and have a block for 7, 8, 9. Take it all the way out to probably midnight or beyond. The next thing I want you to do is I want you to list when are you going to take the client's blood sugar, because this is going to drive the bus a little bit. So typically blood sugars for regular insulin, Accu-Checks are done ACHS. Hope you know what that means. Plot the time that you're going to do that, okay, under that grid. After that, I want you to add another row and says, in conjunction with those Accu-Checks, when is the client going to eat? You might see some connections there. After that, I want you to take regular insulin, and I want you to time out with every administration. You're going to do this you're going to administer insulin 4 times throughout a 24-hour period. So, for every administration, write in when is that dose going to have onset, when will it peak, and when will it complete its duration. When you're thinking about that, now once you do that, I think you're kindly going to find some connections. You're going to see how the blood sugar of a client can fluctuate, possibly, and you're going to see that more in practice. You need to have a patient to do that, but you know when you're checking them versus their food and the onset, the peak, and the duration. If you do that for me, I think it's going to help you with discussion forum 1. So some other considerations that you want to be familiar with and understand are listed here on this slide, so let's talk about them. Warning insulin. This is where insulin decreases at night, and as it decreases, the blood glucose is going to rise. So you may see that. What commonly happens is the type or frequency of the insulin that they're on may need to be adjusted. Dawn phenomenon. This is when there's an increase of cortisol production. Cortisol is going to increase those blood glucose levels, so there may need to be some adjustments with insulin as well. And then finally, the Somogy phenomenon. This is less common. You can see an increase either in insulin, increase in alcohol use, maybe not eating meals. This is going to drive that blood glucose down and have a rebound fall of blood glucose. The body's then going to increase that blood glucose level with cortisol, and you might see an increase in blood glucose in the morning. All right, so let's get into our prototype drug, and we're going to focus specifically on regular insulin. Again, you do need to be familiar with the other types of insulin, and I know it's a lot, but I think if you can wrap your brain around regular insulin, because this is one of the most common that you see in practice, then I think you can better understand the others. So we're going to go down a couple of bullets on here. The mechanism of action or use. Insulin is going to help glucose enter the cells. There's the gatekeeper. It may be used with other insulins, so they may be on more than one type, or your clients may also be on oral anti-diabetic agents as well. We're going to talk about that in our second segment with type 2. It can also be used to treat diabetic ketoacidosis as well as gestational diabetes. So when we're thinking across the lifespan, if a mom does that glucose tolerance test indicative of diabetes, it would not be uncommon to see them for the duration of their pregnancy have to monitor those blood glucose levels and take insulin as needed. Administration considerations. You need to know the blood glucose level, of course, because that's going to drive the bus. You need to know the food. That's also going to play. And the timing of administration to include onset, peak, and duration. Be familiar with and know that this is the only type of insulin that can be delivered IV. So if in the event subcutaneous isn't working for your patients, maybe you're on a med-surg floor, it wouldn't be uncommon if there wasn't management and tight glycemic control that a client would have to be transferred to a higher level of care, a progressive care, or potentially an ICU setting so that they can administer that IV and titrate that drip. You're very familiar with med admin subcutaneous. You always want to rotate the sites. And I always ask students, well, why do we want to rotate the sites? And everybody tells me it's to prevent irritation. True. Okay, but there's a little bit more. You don't want it to get irritated, but as you're continually always using the same site, fat cells may accumulate, and this could cause a problem with onset peak duration, processing of the medication getting through the body, and then the whole plan can go out of whack. So just know that we do rotate sites, and yes, you do know why. Just add in a little bit more for you on that one. You really need to, I need to stay here for a minute. You need to teach your patients this, because they like where they know to rotate. They more than likely do, especially if they've been doing this for a while and they're doing sub-Q. But you want to just go ahead and remind them of that. As always, look for adverse effects with medications. This is paramount. Side effects, adverse effects. Particularly with regular insulin, we need to monitor. Okay, so we're giving it because the blood sugar is high. So we need to monitor. You got it. Hypoglycemia. You need to know what the manifestations of that are and what you will see in your patient. And then you need to put it in words and teaching that they understand based on their ability. Because remember, when we talked about assessment nursing process, we talked about patient education. I can say hypoglycemia all day, but how does that register if I'm a patient when I don't know what that big nurse word means? So one of the things that I do when I teach hyper and hypoglycemia, I start with a little saying, and then we go from there. So I always say, hot and dry, my sugar's too high, cool and clammy, I need candy. Perfect way to tie in some manifestations of either hyper or hypo. And then you can take it from there. Contraindications, we always need to know what the contraindications are, because you are the nurse. You are the last stop before a client gets a medication, whatever the medication is. So when we're thinking about regular insulin, you need to understand, remember, diabetes damages the kidneys. Got to look at that renal function, okay? Got to look at the liver function. You know that meds are metabolized in the liver and excreted by the kidneys, and got to look at the liver and make sure it's functioning. Always need to look predominantly with this medication, potassium. There is a dance of insulin and potassium. It's not uncommon to have potassium levels decrease while on insulin. And as you get a little bit farther in the program, we're really going to talk about this with our kidney patients, our chronic patients. So be familiar with potassium, and I know you know the normal level. I hope you are saying it in your head right now or writing it down on your notes, and know what to expect. Is it going to go high? Is it going to go low? And if so, what do I do? Going back to a little bit of fluid and electrolytes. Interventions, your world nurses, as always. I think we already talked about this. I want to add one additional thing on here when we're talking about regular insulin, and this is probably most likely, but don't quote me, going to come into play with every medication. There are these things, these meds, and they are called MAOIs. For the life of me, I can't remember what it is right now, but do you ever watch those farm commercials? And when they get to the part where they're talking really fast and if you contact the doctor and if you are on MAOIs, just know that that is a contraindication with regular insulin as well as many, many others. I will tell you in practice, I've never seen a client on an MAOI, but if I ever saw one, I would just pause for the cause. You need to consider how everything acts together with meds as a nursing intervention, and I know it's a lot. So we're going to talk a little bit more in depth when we get to the nursing process about specific, more in-depth nursing interventions. Labs. I always say this, don't memorize nursing school, but labs you memorize, you know your normals. You need to know if they're going to go higher or they're going to go low based on the medication that you're giving. And there's a lot of labs, so look at the ones that are significant and relevant. Of course, that renal panel, all those electrolytes on there, especially that potassium, did I say that? Basic metabolic panel. It's called a BMP. You're going to look at that. You also need to look at, of course, without saying it, the blood glucose, especially at the point of care. Again, that drives the bus, and that A1C. So we may talk about it a little bit more. Let's just talk about it now. A1C covers over about 3 months. So let me give you the scenario. A client comes in, I'm a diabetic, I'm taking my insulin, I'm healthy lifestyle choices, I'm eating accordingly, point of care blood glucose is perfect. You're like, yay, excellent job. And then the A1C comes back and it's like 8%. No, okay, let's have a conversation, because this is telling us that not all of that is working right. So now you got to go in and dive in and ask some more questions. Herbal food contraindications or things that can affect regular insulin. I always got to bring this in, because, and you got to ask about this, because sometimes patients don't volunteer it. Garlic. Now, I'm not talking about a garlic you're going to put in your pasta, with a meal, but there's garlic supplements that people take on the regular. Ginseng, very common. I know a lot of people that take that, so you need to look at that. This is going to increase the effect of insulin, and ultimately, so if I have more insulin, what happens to my blood sugar? Going to go down. So now I could be at risk for hypoglycemia. I need to know what hypoglycemia is. Then I need to know what to do with it. Again, let's drive back to that protocol. And you'll have a protocol in the hospital, but you have to teach your patients what to do with that. And with every medication, you need to know how to treat it if there is an overdose. So insulin, I think we talked about this. A lot of times, med errors happen. We talked about med errors. Those numbers on that syringe, those units are so very small. Could there be an error there? Too much drawn up in the syringe? If I'm writing an order, which we don't want to do nowadays, but it happens, 2 units of insulin is different than 20 units of insulin. Okay? Insulin's always in units, you know this. A lot of times on dose calc, you'll write milliliters of insulin. There is a huge difference of 1 unit of insulin versus 1 milliliter. So 1 milliliter, deadly. Okay, that's a lot of insulin, especially if your insulin, depending on how it's derived in the vial, because there's different measures. We're not going to go too deep into that, because your regular insulin, usually 100 units per milliliter. So just think about that. If my order says my blood glucose is this, give 1 unit of insulin. That is extremely different than 1 milliliter. Going back to that protocol, we're going to talk more about this with nursing interventions teaching, but basically foods, snacks, bring that glucose level back up if in the event there's too much insulin. Glucose tabs are a great thing. You can buy those at Walmart. I always teach patients, have one at work, have a container at work, have one in your pocketbook if that's what you have, or something like that. Have one at the house. Clients don't like them. They don't taste good. Glucagon you typically see in the hospital setting, but if you're a type 1 diabetic, you are going to have a prescription for this, and you have to teach your patients how to administer it intramuscularly in the event that there's an emergent situation, and make sure that caregivers know as well. Dextrose IV, again, that's part of a whole protocol. This is IV. It is like pancake syrup. It is clear. It is in a big syringe. It is IV push. It's going to have a rapid onset. You're probably going to use this more often in the hospital setting. If you take a client's blood sugar, and this is a true story, and it is 30, that's why I tell you to memorize your protocol. All right, my nurse brain's already thinking point of care blood glucose. I'm probably going to take it again just to be sure. Or if the meter doesn't read and it's saying too low, I'm immediately going to pull out of the Pyxis some dextrose and administer that IV push. And then I'm going to stay with my patients and continually take the blood glucose level so that I can see if it's working. Again, do this for me. Not today, not tomorrow. Whenever you go to clinic, go find that protocol for hypoglycemia and take a look at it. All right, nursing process, one of my favorite things, because this is what we do, nurses. We have to add pie. So I'm going to go ahead and bring to your attention a few things that you're going to do within the nursing process. And I think I've talked about a lot of them already, so if I do, maybe you'll hear it again. Repeat, reinforce, remediate. Assessment, always a complete history, focusing on those meds. When we're talking about diabetics and insulin, got to ask about those meals, their lifestyle choices. When we're assessing, always look at those vital signs. Definitely looking at that blood glucose and the A1C. We're probably going to talk about it a little bit more later, but when we're doing assessment, I just want to bring back to your attention, this is nursing practice. You've got to have your baseline data, and then you have to look at trends, especially with vital signs and lab values. So my general rule of thumb with students, or in my own practice, is I look at the last 3. And maybe even go back to see what they were on admission if they've been in the hospital for a while for vital signs and labs. Always with labs, look at the CBC. Just do that. Renal, of course, because we need to look at that potassium. We need to look at the renal function. We need to look at the basic metabolic panel. That is going to show how things are working. A1C, yet again, and throw in the lipids on there too, because when you start talking about diabetes, now we start going into a thing I call a triad, and it's diabetes, and it's hypertension, and it's hyperlipidemia. You're going to continually assess. Again, keep going back to those labs. Look at the trending data. Start putting those pieces together. You're the nurse and you're critically thinking and you're saying, okay, my client has diabetes, they're on regular insulin. What I should see with, let's just say the blood glucose, is that it was high. We implemented pharmacology and interventions, and you should see a gradual trend down over a couple of sets of blood glucose. If you don't, now we know there's something going on and we need to revise our plan of care. With the A1C, again, the typical percentage you want to see is less than 6.5%. So if you're seeing anything higher than that, there's lots of education we need to do so clients can get their insulin, diet, exercise, regimen under control. It's very indicative. That's one of the things, and I think clients know this, but then, when we go and say, oh, well, your A1C came back, and then they're like, yeah, now let's have the real conversation. So get that rapport and get your clients, tell them, be honest, there's no judgment here. We just want to help you, right? Need to watch, of course, with assessment, hypoglycemia, and you need to know those manifestations, because if you don't know what you're looking for, you don't know how to intervene. And hyper and hypoglycemia, in a nutshell, can be deadly. On the diagnosis side of things, you have to prioritize. So when we're talking about insulin and medication administration, the one that comes to the top of my brain is risk for injury, and this is related to medication administration of insulin. Others that come are risk for infection. They have decreased sensation, all those other things, step on a rock, attack, or something like that, don't feel it. It develops into an infection, and then once the infectious process starts, if it goes too long, that could be deadly with sepsis. Imbalanced nutrition, well, insulin administration, diabetes, and meal choice all play together in the sandbox, so definitely that would be appropriate nursing diagnosis, healthcare management, and as always, deficient knowledge, especially for brandly new diagnosed diabetic clients. It's very intensive. When you're planning, you want to create outcomes with your client, again, to fix the problems. What do we want them to achieve? Is it education-wise? Are they new? Outcomes, state me 3 signs of hyperglycemia or hypoglycemia, hyper or hypo. Goodness gracious. Maybe I'm teaching them how to administer. The client will self-administer insulin subcutaneously by the end of the shift. Keep it smart. Nursing interventions, continued assessment as always. I think we beat blood glucose levels at point of care to death. Look at your labs. Know your correct administration. You guys are familiar with subcutaneous, the psychomotor skill of it, the understanding, rotate sites, gloves, alcohol swabs. We're going to talk more probably in teaching, but nurses, the patient has to be able to do this. And you have to know they have to be able to administer insulin before they go home. Monitor your intake and output, especially meal consumption. So let's talk about delegation. Can you delegate documentation of meal consumption to an unlicensed assistive personnel like a CNA 1 or 2? And you're all saying, yeah, of course I can. And I should, because I need to do my nursing assessments and I need to do my nurse role. When you're delegating, especially with this, it's very easy. You go in there, the tray's in there, somebody takes it out, maybe the nurse aide took it out, they document it, we can make a typo. Maybe the nurse took it out and the aide didn't see it. Well, now they document 0 because they think the client didn't eat. There's a lot of things that can go with this. So when you're delegating and this is happening, you really have to get on board, have a team aspect with your nursing assistants, and make sure they know what they're looking at, how to determine a percentage of meal consumption, how to document it, how to follow up, and then, let's go delegation, right person, right task, all of those things come into play. And then nurses, you follow up. Eventually you'll develop rapport with your team members and develop trust. You're going to have to follow up and make sure that it was done correctly. Watch for manifestations of hyper or hypo. Bring to your attention the body response when we are sick or stressed can increase insulin levels. So I know we're talking about type 1 and insulin, but also understand that there are other factors that increase blood glucose levels, and you need to know that, so that you can explain to your patient who has never been on insulin a day in their life, and you put them in the hospital and they're like, why are you doing this? I don't want that. So we'll talk a little bit specific a little bit later about that. Storage, not going to dive too deep on it, but you need to understand that some insulins may need to be refrigerated. It varies. Typically in the hospital setting, there were very few that were in the refrigerator. Most importantly, everything has an expiration date. Every medication has an expiration date, and insulins expire. However, let's just stay here. Let's talk about healthcare systems. Let's talk about our client. You know, the one that came in with diabetes now and is on insulin. Oh, by the way, let's add the full picture to them. I don't have any health insurance. Okay, I have a job, but they don't offer insurance, or I have no job and I have no insurance. I can't get Medicare, I can't get Medicaid. It's pretty expensive. That insulin, expensive. Those syringes, yeah, expensive. Everything's expensive in my world. Glucometer, you want me to check? I got to go buy one of those? I got to get a prescription for one of those? Okay, well, I can go to Walmart, spend $10. Those strips, those are expensive. So here's kind of what happens sometimes. This is a true story. Okay, I have to do this now, especially with the glucometer. You know what? I can't afford that. I really can't. But my friend has one. About 5 years ago, she had gestational diabetes, and she got a monitor and some strips and the agents to check it. So I'm just going to go run down to her house and get that, and I'm just going to use that, and that's going to be good. Nurses, we got to find some resources for our patients, because they do it, people do it, just like antibiotic. Let me hang on to that for a minute for next time. Let's try to get some resources involved. And then ultimately you're going to evaluate if client met outcomes. We talked about this in the nursing process aspect. So if an outcome was to no manifestations, administer insulin, emergency considerations for hypoglycemia or hyperglycemia, we need to make sure that they've met those outcomes. And if we don't, we need to get to the root and find out why, revise our plan of care, and let's continue on. Oh, I always promise teaching and education, right? So, final slide, I think. We're getting there. And thank you for staying with me. Let's reinforce. Let's focus on teaching and education, because I will tell you this, with diabetic clients, newly diabetic clients, this is the important piece. That being said, you're probably sitting there going, this is a lot. This is a lot for me to learn. Could you only imagine a patient that doesn't have the background and knowledge that you do? How overwhelming. So, who do we call? Diabetic educator if you have one, okay? Because you're going to be very nursey. You're going to be very busy nurses, and this takes time. So if you have a diabetic educator, you may need to get a consult for that. As always, teach your client signs and symptoms, hyper, hypo. When do I need to call the doctor? And that is mandatory, and we may touch it more in the emergency section. So you have to. Not only do you have to teach it, not only do you have to document that you taught it and how the client understood or did not understand, but you got to document. You got to document in the record, okay? And you have to give them information that are appropriate to their learning. You have to give them a handout, make it so they can read it, videos, demonstrations, whatever you need to do. Appropriate administration, we already talked about this. Storage, rotating sites, types of insulin and what they do. Technique, gloves, alcohol pads. Okay, so let's go back to technique. Your clients, you're going to give them an insulin syringe. If you have an injector pad in the facility, great. If not, a piece of fruit from the cafeteria and let's stick an orange or something, okay? And then here you are, and the client cannot draw up 5 units of insulin. They keep drawing up 15. Why? What's going on? And while they're doing that, their hands are shaking. They cannot get, before they even draw it up, they can't even get it into the vial. And they keep breaking that very fine needle. Why? So these are just some examples. You also need to look at when you're teaching and doing administration. That was a true story. Client had arthritis, and they were having arthritis pain, so it made it very hard for them to manipulate that tiny little vial and that tiny little syringe. In addition to that, you know how small those units of measure are on that syringe? If you're lucky, you have a U100 syringe in there, and that's 100 units, but you want me to get 15? I said, what's going on? She finally told me, baby, I left my glasses at home. I can't see this. Now we've gotten to the root of the problem. So you always need to look at psychomotor ability, hand skills, other comorbid conditions, and yeah, don't forget about the visual aspect. Okay? That's a point. Okay, we're going to stop for a minute. Let me go call. Can I call somebody? Can they bring them to you? And then we start it over. Emergencies, tell your clients, teach your clients, carry some snacks. Hot and dry, sugar too high, cool and clammy, need some candy. Maybe I need to have some candy, maybe I need some carb snacks, because in the body, I know we all know this, macronutrients, we need protein, we need carbs, we need fat. Carbs are going to drive the sugar up. Always have their blood glucose monitor checked frequently. Seek medical treatment if the blood glucose typically is lower than 70 milligrams per deciliter, or if it gets too high, and I can't think of a high number right now, but because everybody's high can be different that they deal with. If I have new diabetes, a blood sugar of 200 could cause manifestations. If I have had diabetes for many, many years, my body kind of gets used to it, so to speak. So, it's 400. I'm good. I'm all right. They may not even manifest, so you need to know that. If the meter does not read, that is bad. Okay? They need to seek medical attention. It's either too low, too high. Worst case scenario, the meter hasn't been checked with those agents to make sure it's calibrated. That wouldn't be worst case. That would be like least case. Okay, maybe there's a problem with the meter, but we're going to be on the safe side. If the meter doesn't read, call 911 and go to the ER. Also, again, let's reinforce, when I'm ill and I'm stressed and I'm taking certain medications, my blood glucose will rise. So, true story. There goes that patient. Not a diabetic. Maybe I am a diabetic. I'm in the hospital. I'm very sick. body response, glucose is going to rise. In addition to that, you threw me on this med called prednisone, corticosteroid, steroid. That's going to rise. So you need to make sure that you teach your clients that that can happen. We need to teach them to increase their activity because that's going to help manage that balance. But we're not trying to run the Boston Marathon tomorrow. Let's start small, okay? We want you to increase your activity, healthy lifestyle. So you don't have to go run 4 miles down the road. All you got to do, let's take a walk. Let's walk around the unit. Let's walk around your house. Take the stairs, not the elevator, those kind of things. Swimming, always great. You see that a lot. When there's an activity question, more than likely, swimming's a good option for a lot of disease processes. This is all in an effort to prevent that knowledge deficit. Remember, knowledge deficit is not the I don't want to do it, I know about it and don't want to do it. It is I don't understand as a patient. So always tell them why they're taking the med, get them to understand that, have them repeat it back to you. They need to know the adverse and side effects. They need to have a list of their medications on them at all times. We talked about this in the assessment piece previously. Diabetics need a bracelet, okay? First responders and emergency personnel, ER nurses, doctors, providers, we need to know if you're a diabetic like right now, okay? So they can get a nice little bracelet. They make beautiful ones nowadays. So that's something you want to have your clients do. Got to teach them how to use that monitor and if they have a pump. Now, I'm not going to go in deep with pumps. I want you to know they exist. Pumps are different. They're like IV. Insulin pumps are different. It's like IV pumps. They're all different. If you end up working with diabetic patients that deal with type 1 and pumps, more than likely 100% you're going to get greater education on that in your setting. What they'll do in a general nature is the client will track their carbohydrate intake, they will track their blood glucose, in their pump there's a formula, they figure out how much insulin to give, and this pump will administer the insulin subcutaneously. Some things to know about just insulin, especially type 1 and pumps is, true story, 15-year-old patient, diagnosed with type 1, needs an insulin pump, needs to do AccuChecks, needs to track meals and carbs, needs to track activity. She's 15. All of her friends are doing what 15-year-olds do, and they're going to the beach. Now, I bring the beach up because now I'm thinking an insulin pump, and I got my swimsuit on, and everybody's hanging out. And she explained to me how life-altering that was and how depressed she got. She thought her life was over. And now you have to bring back Kubler-Ross stages of grieving and further education on that and comfort and being there. Our younger clients, I mean, just envision this. You're being told for the rest of your life, this is it. That can be pretty devastating. And we talked about teaching with self-administration, and I gave a couple examples on that. All right, so we made it to the end. I love it. Diabetes, type 1, prototype med, regular insulin. If you have any questions at all, maybe you were going along, maybe you took down some questions. I hope I answered them throughout the presentation, but if I didn't and you still need anything, go ahead and post your questions in the Prep for Exam forum, Prep for Exam 1 of your Blackboard course.